Your ASCVD patients can't see LDL-C, can't feel it or hear it, but it's there. If they have certain risk factors and LDL-C at or above 55, they could be living in the red, at very high risk of another MI or stroke. But you have the power to help your patients. See the ACC LDL-C recommendations at attackheartdisease.com/HCP.
Worldwide, cardiovascular disease affects the lives of hundreds of millions. Dedicated CardioNerds everywhere are working hard to fight this global epidemic. These are their stories.
Hey CardioNerds, it's Amit Goyal. Welcome back and join us for our very first trip to Detroit to join some CardioNerds at Wayne State University. Thrilled to have on for the first time Doctors Irfan Shafi, Preeya Prakash, and Becca Theisen. Welcome, folks.
Thank you.
Thank you.
Thank you.
Yeah, would you go ahead and introduce yourselves to our audience?
Hey everyone, I'm Irfan Shafi. I'm a third-year cardiology fellow at Wayne State University, Detroit Medical Center. I did my residency and chief residency here as well, and that made me feel head start into the world of cardiology. I am excited to be here in CardioNerds, and I'm getting up for an intervention fellowship at Temple next year.
Hi, everyone. My name is Preeya Prakash. I am the Chief Fellow at Wayne State University DMC in the Adult Cardiology program. I've been here in Detroit for about 10 years, but I'm originally from Salt Lake City, Utah. My goal is to potentially go back out west to do a non-invasive position next year.
My name's Becca. So I am a second-year pediatric cardiology fellow. I was born and raised in Southeast Michigan. I did all of my undergraduate and medical school in this area and was able to stay for residency. I was here at the Detroit Medical Center for a combined internal medicine and pediatrics residency, and I have continued here at the Children's Hospital for pediatric cardiology.
Hey everyone, Dan Ambinder here, and if you can't tell, Irfan, Preeya, and Becca are extremely close and have been traveling together as trainees as they progress through their careers, and you could just tell that they have a great relationship, and so we're really excited to learn a lot from them today. So team, we're in Detroit. Take us to one of your favorite places so we can have a great conversation about cardiology.
All right, today our fellow CardioNerds, we take a journey to the heart of downtown Detroit. It's festive season, so we wanted to go full swing. We decided to hit the ice rink on beautiful Campus Martius here in Detroit downtown. So we'll have twinkling lights, festive decoration, cozy cafes calling us in. So join us as we trade skates for a fascinating case and a lively debate.
Well, this all sounds lovely. And spoiler alert, I think this is our first pediatric case on CardioNerds ever. And as my pediatrician wife would remind me over and over again, that kids are not just small adults. So we are so excited to learn from you all.
Okay, so I can start telling you guys about our patient. This young lady is a bit atypical in her entire presentation, so I think it would have quickly been apparent regardless my involvement in this case. So we will call her FH. She is a 9-year-old female, and she has no known specific medical history. So she initially began complaining of chest pain with activity, specifically riding her bike and running around at recess, along with some associated dyspnea. And her mother took her to a pediatrician earlier this year. This was the first time she had been evaluated at that office. The pediatrician did note a murmur on examination, and she referred the patient to our cardiology department outpatient. They also ordered a cholesterol panel as well as some other basic labs, so a basic metabolic panel, vitamin D level. Her BMP was essentially normal. Her vitamin D was a little low at 10, which is not surprising in Michigan. And her cholesterol panel was grossly abnormal. So her total cholesterol was 802. Her LDL level was 731, and her triglycerides were 123. Mom did receive a phone call about these labs. And I think within a day of the news of the labs being so abnormal, she presented to an emergency department. This was outside of our institution. They completed a chest x-ray and an EKG, which were interpreted as normal, and she was discharged home at that time. This was even knowing that her cholesterol levels were abnormal. But again, she is a very atypical case, so we won't hold that against them. And then within the next 48 hours of being discharged from this outside emergency department, mom brought her to our institution to be evaluated. So she and mom at that point were saying that this chest pain seemed to have really progressed both in severity as well as in frequency. She described it as kind of this sharp stabbing mid-sternal pain, associated dyspnea and diaphoresis episodes. Initially, this was all with physical activity, as I said before, but this did progress to a point where minimal exertion was causing this to happen. And even sometimes at rest, she was feeling the same type of pain. As for the rest of her history, so as I said, she has no known medical or surgical history whatsoever. She was not taking any meds. She had no known allergies. She was in 3rd grade, no specific behavioral or academic concerns. She had notably recently moved from Iraq to the US. So this had happened within several months of her presentation. And this is why her pediatrician who evaluated her in office had only seen her for the first time with this chest pain presentation and had also never listened to her or evaluated this murmur in the past. So that is important for peds patients. If we hear a murmur, we like to see what happens to it over time because there are so many benign pediatric murmurs. So this pediatrician was not sure if this was something that was new for her at that time. The other notable thing about her social history, so her parents are consanguineous, they're first cousins. And so going into her family history a little bit more deeply, it becomes a little more concerning to hear that mom has known elevated cholesterol levels. She says they're in the 300s. She also has known fatty liver history. Dad is reportedly healthy, but mom also says that this guy never goes to the doctor, so she's not really sure if he could have some underlying abnormalities. Maternal grandfather died of cardiac arrest at the age of 65. Paternal grandmother had a myocardial infarction at the age of 40. And both a paternal aunt as well as a maternal aunt have elevated cholesterol that is known. At this point, I think Irfan can help us describe a little bit more about how this patient presented in our emergency department, including her physical examination.
Absolutely. Thank you, Becca. So I just want to give a heads up that we'll see some starking differences in the normal values between pediatric and adult population. Just giving heads up for that. Having said that, on our initial eval in the emergency department, our patient's vital signs showed a normal temperature of 36.9. Her blood pressure was 81 or 49. Again, it's normal for her age. Heart rate of 80, respiratory rate of 24, and she was saturating well on room air. Her weight and height both were at 98th percentile for her age. However, her BMI, which is 21.2, may seem normal for an adult, but was at 90th percentile. So she was overweight from pediatric perspective. Physical exam was unremarkable except for a 3 out of 6 systolic murmur noted at the left upper sternal border. Of note, it did not change with movement. Now, there are multiple pediatric murmurs, as Becca alluded to earlier, that are benign. The intensity of this murmur, as well as its lack of change with movement, make it less likely to be a benign finding. The patient was in no acute distress. I would like to pause here and start considering differential diagnoses. So, Becca, what were your thoughts at this point?
So at this point, we're seeing a child coming in with exertional chest pain, which does raise a lot of red flags, both for a kid and for an adult, obviously. But the vast majority of chest pain presentations in children are non-cardiac. So this is likely why her pediatrician didn't send her to the emergency department right away, even when finding out that her cholesterol was elevated. It's probably why the outside ER also discharged her home rather than referring her to a different center, just because she had a normal, from their interpretation, EKG and also seemed clinically stable. So even knowing this patient's family history as well as these lab findings, her presentation or a presentation of atherosclerotic disease advanced to the point of ischemic heart disease is just extremely unlikely at this age. So I don't think anybody was thinking that at the forefront of their mind. So if we are trying to divide possible differentials at this point, so there are a few non-cardiac etiologies that need to be considered, even with exertional chest pain in a kid. So musculoskeletal is still the most likely presentation that we would see in other pediatric patients. For other kiddos, especially if they're having dyspnea associated with it, you could consider other pulmonary pathology, so pleuritis, even pulmonary embolus, although this patient didn't have any specific known risk factors for that. Cardiac etiology for this type of a presentation, so I think, again, non-coronary types of causes would be considered to be more common. So An inflammatory cause, such as myopericarditis, would probably be at the top of the differential. Less likely, you could also see maybe some genetic syndromes that lead to things that we do see a bit more commonly in the adult world. So if you have a patient with Ehlers-Danlos or Marfan's and they have aortic root dilation leading to dissection, these could be presentations that you could theoretically see in a child. I think knowing that she has exertional chest pain makes you also think of coronary-based etiology. So again, atherosclerotic disease, even knowing her cholesterol levels at this point is not necessarily still the top of the list like it would be in an adult. And that's just because, again, it's exceedingly unlikely to have a disease so advanced at the age of 9 years that you would present in this way. So if you think about other pediatric coronary sorts of issues that could present, more typically you would think of the infectious or post-infectious causes. So your vasculitis entities like Kawasaki disease. I don't know if you guys are reaching back to medical school to think of this, or the multi-system inflammatory disease of children, the MIS-C COVID-related disease. So these can both lead to coronary artery aneurysms and dissection. And then we also have to think of other coronary anomalies. So congenital anomalies like hypoplasia, stenosis, coronaries that are not hooked up to the right space. So your L-kappas or R-kappas, where you have a coronary coming off of a pulmonary artery, which would be less likely to present at this age, by the way. Usually it's much, much earlier. Or coronary arteries that are originating from the wrong coronary cusp. These are all possibilities and can present similarly. Coronary artery spasm could be another thought that you would have as part of your differential, but it's typically more likely when you're seeing certain substance use issues and a little bit less likely in this particular age group.
Thank you, Becca, for that comprehensive differential, which guided the next studies we obtained. So lab work ordered as part of the evaluation included a CRP, which was negative. We also obtained a basic metabolic panel, which did not show any abnormalities. Patient's electrolytes were within normal limits. Patient BU and creatinine was in normal limits. We also obtained CBC, again, hemoglobin, platelet count, all hematocrit were all within normal limits. Patient's liver function test did show an ALK phos of 318, and it may seem a little higher for an adult, but again, Becca educated us that this is a normal finding in children. Also, her calcium, magnesium, protein, albumin, all were within normal limits. What was strikingly elevated was patient's troponin levels, which were 3018 nanograms per liter. And her NT-proBNP was 137 picograms per ml. Her total cholesterol was 802 milligrams per deciliter, triglyceride of 133 milligrams per deciliter, HDL of 46 milligrams per deciliter, LDL of 731 milligrams per deciliter, and non-HDL cholesterol of 756 milligrams per deciliter. At this stage, we also obtained a chest X-ray and an EKG. The EKG was remarkable for T-wave inversions in lead 3, and chest X-ray was negative for any obvious cardiopulmonary process. Now, the EKG, I'm going to refer back to Becca to tell us if this is a notable finding in children.
So T-wave inversions in children are sometimes normal findings. They're not something we always jump at. I will say lead 3 is atypical. You usually see T-wave inversions or these juvenile changes in the precordial leads, particularly the first V1 through V3. That said, if I saw a kid who had none of these symptoms, none of these lab findings, and she had T-wave inversions in lead 3, I might not think too much of it. I might not jump to do anything about it because, of course, this is a child. So why would they have ischemic findings? Now, that said, in this patient, I do think that it's likely that this was related to an ischemic change, although we do not have a baseline EKG to compare it to.
Excellent. At this point, adult cardiology service was also consulted for the concern of possible acute coronary syndrome in this child. At DMC, we're very fortunate because we see very diverse pathologies, and with Children's Hospital right next door, we're often consulted, but usually for adult congenital heart disease cases. However, this particular case piqued our interest. At this stage, I know it's a lot of information to digest, but before we dive deeper into any further diagnoses and workup, I believe it's crucial to address the elephant in the room, the patient's lipids. Now, I think thorough understanding of underlying mechanism behind the lipid metabolism is very crucial. So let's go through the basics. Let's talk about LDL. This is the master of cholesterol transport. Navigates a complex web of interactions in the bloodstream. Its journey begins in the liver, where VLDL particles laden with triglyceride and cholesterol take center stage. Lipoprotein lipase, a skilled sculptor, trims the fat, transforming VLDL into IDL. Finally, the hepatic triglyceride lipase takes the spotlight and then converts IDL into LDL, ready for cholesterol delivery. On the surface of hepatocytes and other cells, you have specific receptors which act as, so to say, concierge, recognizing the ApoB, which is a signature protein attached to LDL, and LDL then attaches to its receptor, gets internalized by endocytosis and degraded into the lysozyme. The ApoB on the LDL is degraded into amino acid and cholesterol esters are further hydrolyzed into fatty acid and cholesterol, and then the cholesterol enters the cell. Of note here, if you have fewer LDL receptors, that means your LDL serum levels are going to be higher and vice versa. Having said that, now let's get back into some of the imaging findings pertinent to our case. Becca?
Yeah, so at this point, we know that we have a child with exertional chest pain. She has possible EKG findings concerning for ischemia. And in addition to that, she has a significantly elevated troponin level as well as an elevated BNP. And this is with known elevated cholesterol as well. So at this point, I do think some of the other differentials I'd mentioned before, like musculoskeletal chest pain, are very unlikely to be causing her presentation. I think we need to consider those other cardiac etiologies, especially those that can cause significantly deranged troponin levels. I do think inflammatory causes like myopericarditis are still possible. However, given the specific EKG findings, we start thinking more about those coronary issues that we discussed. And so in thinking about that, and in thinking about the possibility of abnormal coronary arteries that are congenital in etiology or other types of things related to that, I think the next best step would be to obtain imaging. So we did obtain an echocardiogram as our next step. So I can walk you through or describe at least some of the imaging that we did find. Focus, of course, was made on her coronary anatomy as well as her overall cardiac function, given that we had concerns for ischemia. We also were looking for any other specific types of congenital abnormalities that could have led to this presentation. So the protocol that we follow in pediatrics, and this varies from institution to institution, but in our facility, we like to move from parasternals to apicals to subcostals and do the vast majority of these images just in 2 dimensions. And then we add our Doppler and color and kind of come back through. After that, we kind of move into our high parasternal views as well as some suprasternal views. These are really useful for us to look at our pulmonary anatomy, our pulmonary arteries and veins, look at our ductal view, look at our aortic arch, and also understand the branching patterns of the vessels coming off of it. So in our patient, when we started in her parasternal views, pretty quickly we saw some abnormalities with these. So she did have some mild left ventricular hypertrophy, which was accompanied by some septal hypokinesis, although I will say that subjectively her biventricular function was normal. There were no obvious echo brightness within her myocardium, which we were looking for given the concern for her coronaries. And her papillary muscles were normal appearing as well with normal orientation. Her left coronary artery origin, it did appear somewhat narrow at the origin, and there was some flow acceleration that was seen. She otherwise had normal coronary anatomy, so there was no evidence of ectasia, there were no aneurysms, and there was no anomalous anatomy, so no coronary arteries coming off of the wrong cusp. The cusps of the aortic valve did appear somewhat thick. They were sort of sclerotic looking. They did not open and close correctly. And in long axis, we also saw some really significant narrowing of the supravalvular region of the aortic valve. The mean gradient over that region was 40 millimeters of mercury, and her peak velocity there was 4.4 meters per second. She also had some mild AI. Both of her AV valves were noted to be normal. So seeing all of this, we wanted to better establish her coronary anatomy. Obviously, we can't see everything on an echocardiogram, although I can say we do see a lot more in children than we can see in adults. So the next step for us was obtaining a CT thorax, a CTA actually, which did also reveal this supravalvular aortic stenosis. So the space there measured 1.3 centimeters in the ascending aorta. She also had a diffusely hypoplastic right coronary artery with a dominant left coronary artery system. And there was additionally some obstruction seen at the left coronary artery origin, which corroborated with our echo findings. So after we obtained our CT thorax, we did move on to a diagnostic cardiac cath, where it confirmed severe aortic stenosis. So this was mostly above the level of the valve. And she also had significant coronary artery obstruction noted during that procedure. The aortic valve leaflets were again found to be thickened and dysplastic, and there was insufficiency at that level.
All right. Thanks, Becca. I think this was a really great opportunity for us to really understand the intricacies behind echocardiography from a pediatric standpoint. I think definitely speaking as an adult cardiologist, we don't really know all the different mechanisms and the different ways that we really obtain all these images from a ped standpoint. So this was a really great summary. So looking at our CTA and echocardiography images, let's talk about what we think our primary differential is at this stage. So going through the entire process of going through non-cardiac versus cardiac etiology, our primary differential now at this stage has shifted to acute coronary syndrome. And this is specifically based on the evidence of our wall motion abnormalities on echo, as well as our elevated troponins that we saw in lab work. And this is in the setting of obstructive CAD on our CTA as well as in our diagnostic left heart cath. So these findings are obviously very remarkable in any of the adult patients that Irfan and I would see on a regular basis, but it's definitely not something that we see in our peds patients every single day, right, Becca?
Definitely not. I have never seen this before this patient, so I'm really happy we could discuss her today.
All right, now to summarize, so we have a 9-year-old female presenting with exertional chest pain and dyspnea with a systolic murmur, and she has a very concerning clinical trajectory suggestive of acute coronary syndrome. Now, our comprehensive imaging, including a CT, cath, and echo, delineated the presence of supravalvular aortic stenosis with obstructive coronary artery disease. Notably, the familial predisposition to hypercholesterolemia and the consanguinity underscored a potential diagnosis of familial hypercholesterolemia, FH. And this offers an insight as to what is the possible underlying etiology in her cardiovascular manifestations. So I think at this stage, we need to have a deeper understanding of what is the pathophysiology behind FH and what are the clinical manifestations. So FH is an autosomal dominant disorder, which is caused by mutation in the gene involving in the low-density lipoprotein LDL-C metabolism. There are 3 important genes which are involved. You can have mutation in the LDLR gene, which is the LDL receptor gene, which accounts for 60 to 80% of the cases, followed by the ApoB, which is a protein attached to the LDL in 5 to 10% of the cases, and then PCSK9 in about 1 to 2% of the cases. Now, these mutations can be diverse. They can range from a non-coding regulatory variant to missense mutation to nonsense and splice site mutations. Now, the question comes, who should be screened? As per ACC/AHA guidelines, which were documented in 2018, if a patient has a strong family history of early cardiovascular disease, which they define as disease onset in men less than 55 and in women less than 60, with hypercholesterolemia, then in those cases, the children need to be screened at age 2, and it received a 2A recommendation. In ESC guideline, if the total cholesterol levels are above 190 milligram per deciliter in adults or greater than 150 milligram per deciliter in children, they need to be screened at age 2. Having said that, now let's try and understand the pathophysiology together. To simplify, imagine a bustling dance party where the LDL particle carriers of bad cholesterol are the guests. The hosts are the LDL receptors. They are located on the surface of the liver cells. Now, these receptors act as gatekeepers, welcoming LDL particles, ushering them inside the cells for processing. Now, this process helps keep cholesterol balanced in the blood. But in FH, the dance party gets disrupted. You have mutation in the LDL gene, which can throw the whole event in chaos. And here is how it happens. The first mutation could be you're missing the gatekeepers, which are the LDL receptors. Now, the mutations can prevent production or proper transportation of the LDL receptors to the cell. This means that there aren't enough gatekeepers to handle all those LDL guests. As a result, LDL accumulates in the bloodstream, leads to high cholesterol levels. Second is if you have unrecognized guests at the party. Now, sometimes mutations affect the ApoB, the protein that acts as an identification tag on LDL particles. Now, this makes them unrecognizable to the receptor, like a guest wearing a mask at a party. So, unable to identify them, the LDL receptors can't usher them inside. So, the end result, LDL builds up in the blood. The third possible mutation would be if the guests are having rapid departures. Now, here is where PCSK9 is another key player. PCSK9 is responsible for recycling and degrading the LDL receptors. Now, mutation in the PCSK9 gene can accelerate this process, which leads to a faster turnover of LDL receptors. This means you have few receptors available at any given time, further disrupting the LDL clearance process. Now, in FH, there is a domino effect. The LDL cholesterol builds up, it attacks the arteries, which then causes inflammation, which attracts the inflammatory cells, including macrophages. They form the foam cells, which attracts more trouble, causes plaque formation, which is a tickling bomb, which can rupture and cause MI and stroke. Having said all that, we kind of understand what the underlying pathophysiology is. Now let's see how the phenotype of FH plays. You can be heterozygous for FH. In this scenario, an individual has usually inherited one mutation from each parent, and this results in moderate accumulation of LDL cholesterol in the plasma. And the prevalence of heterozygous FH, which we commonly see in the US, is about 1 in 220 based on genetic studies. Homozygous has two variants, either homozygous FH or compound heterozygous FH. Now, these individuals have either two copies of the same mutated genes, that means they're homozygous, or they have two different mutations, compound heterozygous. Now, this leads to a minimal or almost non-existent functional LDL receptors, which results in significant buildup of LDL and more severe clinical phenotype, and it obviously has worse prognosis. And usually the cardiovascular manifestations are before age 30 in homozygous FH. The frequency is estimated to be about 1 in 300,000. So it's very rare. And although the prevalence of FH in general population is substantial, in studies, only about 15 to 20% of the affected patients receive a formal diagnosis. And patients who are untreated for heterozygous FH have 10 to 20-fold increased risk of premature coronary artery disease. This is for heterozygous, which have way less levels than homozygous. Now, having said that, we kind of understood how FH presents, what are the clinical pathophysiology behind it. Now, let's try to delve into clinical manifestations and diagnosis. Now, diagnosing FH relies on three key clues. Number one, bad cholesterol levels. Number two, family history. Number three, physical signs. High LDL levels, typically above 190 milligram per deciliter, raises suspicion, but lower levels can still suggest FH if there is a strong family history or if there are visible signs. Now, these signs, we read them in the medical school, prepared them for our boards, are when the cholesterol gets deposited, especially they allow tendons, and we call them xanthomas. Xanthelasmas is when they have deposition, particularly under eyelids. And sometimes patients can even have a white ring around the cornea, which is called corneal arcus. Interestingly, these criteria do not apply to patients with severe form of FH, the homozygous form. So our patient did not have any of these signs. However, in homozygous, you usually suspect a patient to have homozygous FH if their LDL levels are extremely high. In studies, they have reported if the untreated levels are above 500 or if treated levels are about 300, this should strongly raise suspicion for homozygous FH. Now, there are a lot of scores-based diagnostic tools which are available for us and which can help us sort of risk stratify these patients. The most popularly used in US are the Dutch Lipid Network score as well as the Simon Broom registry. Now, these scores are based on factors like DNA mutations, the lipid panel levels, presence of xanthomas, family history, and eye findings. And each of these will get a score, either 1 or 2 or 3 or 4. And usually, if your score is higher than 8, there is a definitive diagnosis for FH. Having said that, FH remains a clinical diagnosis, but you need confirmation with genetic testing. The FH Foundation recommends genetic testing in patients who have a definitive or probable diagnosis, along with cascade screening. Now, cascade screening is when you check LDL levels and do genetic testing, and it's usually done on first degree relatives. The presence of a causal genetic mutations carries significant risk that compounds the elevation in LDL. And in FH patients, when the LDL levels are above 190, they have 20-fold higher risk of coronary artery disease. Now, there are important caveats in the molecular diagnosis of FH. Individuals with a clinical diagnosis of definitive FH are found to harbor mutation only in 60 to 80% of the cases. The bottom line, there is no single method perfectly available right now to diagnose FH, but you have to take sort of a multi-pronged approach. You have to take into consideration the clinical findings, the family history, and also the genetic testing. I'm going to defer to Preeya to talk further about the case.
Well, Irfan, that was, an exceptional overview of the pathophysiology as well as the clinical manifestations. I don't think I ever even had that kind of overview during med school. So this was definitely a great refresher. And with boards coming up next year, I'm really going to owe you one. So thanks. So now that we've made our way to our diagnosis, what would be our next steps for treatment and management? So let's talk about from an initial treatment perspective to begin with, surgical intervention. So given the severity of our patient's presentation and her clinical manifestations, the decision was made to proceed with surgery. The surgical procedure included the Ross operation. So she had a size 22 cryopreserved pulmonary homograph to reestablish her RV to PA connection. She also had left main coronary artery augmentation using a native pulmonary artery patch with reimplantation of her native RCA to the neo-aortic root. Intraoperatively, they actually found that there was extensive atherosclerotic plaques on both the ascending aorta, on the aortic valve, on the anterior mitral leaflet, and the coronary arteries. So for those of you keeping score, the reason why the Ross operation was actually proceeded with was because there was evidence of atherosclerotic plaque on the valves, specifically on the aortic valve. Her surgery overall was actually uneventful, and she tolerated the procedure very well. All right, so now that we understand the thought process towards our diagnosis and the surgical management, what would be our next steps for the targeted medical management and management of homozygous FH? So our two main areas that we're going to focus on are to target the mutations in the LDLR receptor pathway that Irfan already discussed. So in our patient, given that she had two mutations in the LDL receptor pathway, she was considered an FH homozygote. So the medications that we use, statins, bile acid resins, and PCSK9 inhibitors, they all serve to enhance the expression of LDLR. In patients who are heterozygotes, like Irfan talked about, there's some amount of efficacy in these agents because there is presence of LDLR. But in patients who are homozygotes with no or little receptor activity, the efficacy of these medications is likely void. So in these patients who are diagnosed as homozygotes, LDL apheresis is a really important step in the management of FH, and it actually may need to be a part of chronic and continued management in these specific patients. There's multiple different methods that can be used for apheresis, including plasma exchange, double filtration, and LDL adsorption. And this really depends on what's available at the facility and also within the specific patient itself. All right, one thing to note is that LDL apheresis is very safely performed in children, and it's had no impact on development or growth levels. The mechanism of action of apheresis, beyond actually lowering LDL levels, is also that it potentially inhibits cell adhesion molecules and lowers thrombus formation by decreasing fibrinogen and coagulation factor levels. So it's really beneficial in the overall prevention of atherosclerotic buildup. Apheresis itself should be initiated as early as possible once diagnosis has been achieved. But one thing to keep in mind, and especially since we're talking about our pediatric population, it can be really difficult to expect our patient, especially if they're a young kid, to keep still for the entire duration of treatment. So really keep this in mind. I also wanted to briefly touch on how PCSK9 functions in the specific pathway. PCSK9 itself is known to be involved in the degradation of the LDL receptor. It's a gain of function mutation of PCSK9, which occurs in the setting of FH, actually causes increased breakdown of the LDL receptors and therefore the hyper-LDL state. However, in those who are homozygotes and don't have the LDL receptors, the effect of a PCSK9 actually could be null and void as well. Therefore, it's important to tailor each therapeutic option accordingly. So while we have all of these treatment options available, what are our target LDL-C levels that providers should reach for effective response, especially when we're considering our pediatric population as well? As Irfan already explained so well, there are multiple different criteria in establishing targeted levels. In heterozygote pediatric populations, if the LDL-C level is persistently above 180 milligrams per deciliter, even after dietary and lifestyle modifications, then medical therapy should be considered in children above the age of 10. The targeted LDL goal in this patient population is below 135 milligrams per deciliter. In homozygous patients and in patients with other risk factors present, such as diabetes or even hypertension in this patient population, the treatment regimens become more aggressive and are more focused on secondary prevention. Ideal LDL-C levels are below 100 milligrams per deciliter for primary prevention and below 70 milligrams per deciliter for secondary prevention. But it can be incredibly difficult to achieve, and we actually saw this in our patient as well. Overall, the main goal of initial treatment and further management of these patients is in addressing the LDL burden itself. So it can be really tricky to delineate which cutoff level to really target, but the consensus is very clear in terms of which therapeutic agents can be used in the specific population, as well as the true benefit of lifestyle modification, including exercise therapy and dietary modifications. So the actual initial guidelines, which stemmed from the Japanese Atherosclerotic Society, recommended a diet with saturated fats limited to about 4.5 to 7% as part of the diet, a huge reduction in trans fat intake, and also to limit cholesterol intake to less than 200 milligrams per day. So now that we've gone through the targeted medical management that's used nowadays, where is the science actually leading us in terms of new and innovative therapies in the FH realm? So there are actually novel biologic and mRNA therapies for patients who have difficulty achieving targeted LDL-C levels, especially in our homozygous population. Evanicumab is an ANGPTL3 inhibitor, which works to bind to the circulating levels of ANGPTL3. This molecule actually acts specifically in the pathway of triglyceride metabolism. So it inhibits the activity of lipoprotein lipase, which prevents the conversion, like Irfan mentioned, of VLDL, and therefore the clearance of LDL-C from our system. That actually prevents the hydrolysis of these molecules into the free fatty acids, and then you actually get buildup of these agents. So if you block ANGPTL3, there's actually an increase in LPL levels, and thereby you actually get increased VLDL clearance. So that downstream leads to lower levels of triglycerides, lower levels of LDL-C, but the best part about this is that this happens in an LDL receptor independent manner. So this is a great targeted therapy to use in our patient population that are homozygotes because they don't have that LDL receptor available. Some recent advancements have actually been made as well within mRNA therapy. Adenovirus and exosomes are used as genetic vectors for targeted therapies in the genetic mutations that we discussed above. And clinical trials are being conducted to assess the efficacy and possible side effects. One side note I wanted to mention, at the recent AHA 2023 meeting, there were promising findings on the use of CRISPR therapy in reducing LDL-C and PCSK9 levels in patients with heterozygous FH, with the Verve 101 trial. The use of these gene therapies could have huge positive implications on the focused therapies in these specific patient populations. So I think this is a really exciting area of development that I'm sure many of us hope to see come to fruition within our clinical practice lifetimes. So now that we've touched on not only the targeted medical therapies, but also the therapies that we hope to see in the future, let's go back to our postoperative course for our patient and see how she's doing and see what we can potentially do to further help with her management and treatment course. So her post-op surgery recovery, like I said before, was uneventful. She did actually undergo plasmapheresis multiple times during admission. She was discharged on a regimen of atorvastatin, ezetimibe, evolocumab, and antiplatelet therapy. She did end up having regular plasmapheresis sessions that were initiated to manage her persistently high LDL levels. Despite this treatment, her LDL levels remained elevated, so she needed to have ongoing lipid management. Therefore, she was started on evinacumab infusions every 4 weeks, along with intensive dietary changes. Her LDL levels since then have actually dropped below our anticipated goal. She's around 90 milligrams per deciliter. She does have a repeated cath planned within the next few months. Her overall outpatient care team right now includes not only pediatric cardiology, but also the medical genetics team, the lipid clinic, which includes a dietitian as well, the endocrinology team, and GI. And the reason GI is on board is because she may actually end up requiring an eventual heart and liver transplant to further help management down the line. So, this really concludes our case. It really gives us a good insight into not only what the steps we have to take in terms of initial diagnosis, imaging, lab work, and kind of moving forward from there, but also how tricky it can be in terms of medical management and also moving forward in terms of treatment options.
Wow, terrific case. When I was 9 years old, I think I was in third grade in Brooklyn. And the biggest thing on my mind back then was, what movie are we going to watch for next Friday's family movie night? Our dear patient here, her 9-year-old childhood is a little bit different. And my heart goes out to her and her family for everything they went through. But as you went through this case, I am struck by an observation here. On the one hand, she's got supravalvular stenosis, some sort of mechanical obstruction from a connective tissue disorder of some sort. And on the other hand, she's got familial hypercholesterolemia with really monstrously elevated cholesterol, presumably leading to plaque. And she comes in with acute onset chest pain, worse with exertion, with a finding of coronary stenosis, which may very well be plaque rupture. But on the other hand, with sort of osteoleft main stenosis, you could also consider, was this related in some way to her valvulopathy/uretopathy? So how did you guys think that her aortic manifestation and her coronary manifestation sort of were true unrelated, or is there a way we can put those things together for her?
No, so just to offer a little bit of clarity on this. So the supravalvular aortic narrowing that was seen, and actually this was corroborated intraoperatively. Our surgeon does have photos of this too, which I can try to send you guys. But that whole blockage in the pathway was all atherosclerotic plaques. So this supravalvular narrowing was basically just a bunch of that atherosclerotic tissue. So it was all related. It was entirely related to this one etiology. This isn't actually unique to her. So if you go, there's a lot of different case presentations that you can find, but a lot of people, especially homozygotes for FH, do have this sort of supravalvular aortic narrowing, and it's all this atherosclerotic plaque gathering.
Wow, I had actually never heard of that. So thank you for bringing this to us and teaching us. And I'll say that my pediatrics rotation was my first where we transitioned clinicals in medical school, and I had a blast. I really enjoyed it. I remember some of my patients very well still. And then I found myself studying from a shelf exam at the end of that rotation. And I was at a coffee shop and I look outside and there are all these kids, laughing and playing outside. And I realized all of a sudden that, that just seeing kids in a hospital sick just had this effect on me. And it was so great to see them outside. I realized that day that I was not built to become a pediatrician. So hats off to you, Becca, and so many others. And it's amazing what you were able to do for this 9-year-old. Thanks for bringing this to us.
Her recovery through this was also pretty incredible. I mean, that operation, I think, was really significant, and the burden of her coronary disease was pretty scary, but she pulled through it very, very nicely. So I think that speaks to how incredible children are.
Yeah, very resilient. Well, thanks, team.
Thank you. Thanks so much.
Yeah, team, this was absolutely amazing. Just thinking about the different topics that we covered today in terms of teaching, this case presentation just illustrated so much. And Amit and I were talking in the background, just we're covering genetics, novel targeted therapies, lipidology, aortic stenosis, and the Ross procedure. It's just the way that you were all able to go through this case, take us through this patient's journey, but then highlight so many different aspects of cardiovascular medicine along the way. It's unreal. So just thank you so much. This was such an enjoyable recording session.
Oh, thank you guys so much.
Thank you.
We really had a good time, and I think a really educational time coming up with this case. And we're, like Irfan said before, we're really lucky to be here at DMC, specifically because we get to have children in our backyard and we get to really pick their brains too. So I think we've been kind of blessed to have that collaboration. So now I'd like to invite our faculty expert, Dr. Louis C. Afonso. He is our current Chief of Cardiology over here at Wayne State University DMC. He's also our program director. He serves as a professor of Wayne State University School of Medicine. And he's also the director of our echocardiography laboratory. So Dr. Afonso definitely wears many hats in our fellowship, and we are incredibly grateful and incredibly privileged to have him as one of our educators. I think Irfan and myself both have benefited from his training, myself since medical school and Irfan since residency. So we're very excited that he will be our faculty expert for this case and will be able to provide more insight into our patient's medical journey. So we'll turn it over to Dr. Afonso.
Thank you, Preeya, for that generous introduction. Hello, everyone. Before I begin, I would like to thank the CardioNerds leadership for graciously hosting us. And of course, a big shout out to our stellar team of fellows, Irfan, Becca, and Preeya, for their superb presentation. It's truly an honor to be able to say a few words on this most fascinating case. The details of the case have already been comprehensively covered, and so I will limit my comments to some teaching points that emerged as this case unfolded. Back in May last year, I happened to be there attending on our consult service when we were asked to see this 9-year-old girl who presented with chest pain and elevated troponins. Now, age notwithstanding, she endorsed the classic story of crescendo angina that had progressed over a period of weeks to angina at rest and a syncopal spell on the night prior to admission. While her story was very compelling, her physical exam was relatively underwhelming. As a quick aside for trainees in the audience, unlike patients with valvular aortic stenosis, individuals with supravalvular stenosis often have a systolic thrill palpable in the suprasternal notch. One may also encounter discrepant blood pressures with disproportionate elevation of blood pressure in the right arm relative to the left arm, a finding attributed to the Coanda effect. A review of her echocardiogram, amongst other findings, demonstrated systolic turbulence in the aortic root with focal narrowing of the supravalvular aorta. Hypoechoic focal thickening of the aortic wall at the site of luminal compromise appeared to suggest cholesterol deposition. This was in fact later confirmed on our patient's histopath that revealed foam cells, cholesterol clefts, and fibromyxoid degeneration in the biopsied aorta. The aortic valve appeared thickened with mildly restricted cusp mobility, pointing to supravalvular stenosis as the proximate cause of the elevated transaortic gradients. Here again, be reminded that elevated transaortic Doppler velocities with a parabolic CW envelope point to a fixed obstruction. In the absence of valvular or supravalvular stenosis, look for LVOT obstruction, either from a discrete subaortic membrane, a fibromuscular ridge, or even disproportionate upper septal hypertrophy. PW Doppler and a frame-by-frame appraisal of flow convergence will help localize the site of obstruction. Now, Rebecca did a marvelous job going over a broad differential diagnosis. I would just like to say that based on the echo findings alone, and absent the results of the lipid panel, one would have to consider supravalvular aortic stenosis secondary to elastin arteriopathy in the differential. Elastin arteriopathy disproportionately affects the ascending aorta, manifesting in a non-syndromic manner or with syndromic presentations such as in the Williams syndrome. This entity can also present with symptoms of dyspnea, angina, and heart failure. Stenosis of the coronaries and pulmonary arteries have been described in these patients. Our patient's CT angio revealed a diminutive right coronary without collaterals and ostial left main stenosis. A subsequent invasive angiogram confirmed these findings. Just a quick word of caution related to the performance of coronary angiography in these situations, and that is, when you have a patient with suspected left main disease, particularly ostial left main, it's advisable to refrain from selectively engaging the left coronary artery for fear of displacing soft plaque. Matter of fact, an aortogram alone, preferably with biplane projections, as was done in our patient, will often suffice and provide the surgeon with adequate actionable data to plan revascularization. You're already familiar with the details of this case and the gratifying postoperative outcome in our patient, who, by the way, continues to do very well. At this juncture, I would like to switch gears and offer a few supplemental remarks on therapeutic options for patients with FH. In terms of LDL targets, European guidelines recommend goal LDL of less than 55 for FH patients with clinical ASCVD. That said, initiating statins and ezetimibe together seems to be a reasonable first step. Statins are the mainstay of treatment and lead to LDL reductions of 10 to 25% in the majority of patients, even in those with LDL receptor negative FH. Ezetimibe, as you well know, inhibits intestinal cholesterol transport by blocking the Niemann-Pick-like protein. This leads to an upregulation of LDL receptors that typically translates into 15-20% reduction in LDL levels. The next logical step in the treatment of FH would be to add PCSK9 inhibitors. As you've already heard, these agents safely lower LDL, although efficacy is dependent on residual LDL receptor activity. Treatment may be ineffective in approximately a third of patients with homozygous FH. Alirocumab and evolocumab are FDA approved for homozygous FH. You can expect a further 15 to 30% LDL reduction with these agents. Moving on to lipoprotein apheresis, this refers to the extracorporeal removal of circulating ApoB-containing proteins. Besides LDL, these include lipoprotein a and VLDL. Typically, weekly or biweekly sessions are needed, and the frequency of sessions is predicated in part by the rate at which LDL levels return to baseline post-treatment. The cost per session runs in the range of $3,000 to $4,000. Apheresis lowers LDL acutely by a whopping 50 to 76%. As alluded to earlier by Preeya, for decades, apheresis has served as the cornerstone of therapy, particularly for children less than 12 years and pregnant women with FH. The literature contains numerous case reports of children with homozygous FH undergoing long-term apheresis. These reports describe impressive regression of xanthomas, coronary and aortic lesions, as well as prevention of de novo vascular lesions. Next, you may also have heard of this tongue twister, lometopide, an oral MTP inhibitor. MTP stands for microsomal triglyceride transfer protein. And MTP inhibition leads to a reduction in the secretion of chylomicrons and VLDL. The mechanism of action is independent of LDL receptor function. This drug received FDA approval in 2012, but only for patients above 18 years of age. Declines in LDL of approximately 40 to 50% are typical. Liver toxicity and CYP450 interactions need to be monitored while on this medication. I must say I was somewhat dumbstruck by reports describing children as young as 5 years of age who normalized the LDL levels, mind you, in less than a week following transplant surgery. Liver transplantation simply provides FH patients with the functional hepatic LDL receptors they lack. Again, transplantation is particularly appealing in young kids in whom pharmacologic options may be limited. I would like to spend the last few minutes going over some truly spectacular developments in the FH space, particularly in the realm of biologics. These therapeutics have offered renewed hope for patients with homozygous FH, both children and adults. First up, ANGPTL3 antibodies. As mentioned, angiopoietin-like 3 protein is a hormone produced by the liver that inhibits endothelial lipase and lipoprotein lipase. The fully human monoclonal antibody evinacumab binds circulating ANGPTL3 and leads to declines of LDL in the ballpark of 50%. This is truly incredible efficacy in the setting of homozygous FH. This agent received FDA approval in 2021 for patients aged 5 years and older. The dose, 15 milligrams per kg, as an infusion administered every 4 weeks. Case in point, our patient dropped her LDL from 129 to 42 milligrams per deciliter following just 3 infusions of this agent. This has allowed her to come off apheresis altogether. Finally, the crowning glory of genome engineering. Yes, game-changing CRISPR. CRISPR-Cas9 genome editing was first shown to permanently restore LDL receptor-mediated endocytosis in pluripotent cells, stem cells of patients with homozygous FH. This demonstrated proof of principle that genetic modification can normalize cholesterol metabolism at the cellular level. Close on the heels of this report, the initial results of the first human trial of an investigational treatment, VERVE 101, were presented at the AHA late last year. This agent permanently turns off PCSK9 gene in the liver. In this study of 10 patients with heterozygous FH, a single dose of gene editing therapy led to sustained LDL reductions of 55% for up to 6 months and counting. The study is ongoing, but these preliminary findings are indeed surreal and super exciting. So in conclusion, I think we can all agree that there have been unprecedented advances in treatment options for patients with homozygous FH. I will go out on a limb and say that the prospects of effective, long-term, or even permanent treatment for elevated LDL might soon become reality, that too in the not-so-distant future. And with that, I would like to thank you for your kind attention.
Thanks for tuning in to another CardioNerds episode. The audio editing for this episode was performed by me, Pace Wetstein. I am an intern in the CardioNerds Academy, House Jones, and an MS1 at LeCom Seton Hill. I invite you to check out the episode page for show notes and references. If you found this episode informative, please consider subscribing to CardioNerds on your favorite podcast platform and leaving us a review. It helps us spread the word and further our goal to democratize cardiovascular education. Finally, this podcast is not meant to be used for medical advice. The views expressed on our show and site do not reflect the opinions or policies of our employers. All CardioNerds content is planned, produced, and reviewed solely by CardioNerds. Stay tuned for more engaging conversations and explorations in our upcoming episodes. And now, it's time to make like an S2 and split.